Hello and welcome. I'm Dr. Deepak Bhatt. It's really great to have you here on a Sunday night for those of us that are joining live, and I know there are a lot of people joining live. And for those that are watching this in the archive version, welcome to you as well. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity titled Weighing the Evidence, a pharmacy approach to stroke prevention in obese patients with non-valvular atrial fibrillation. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us today on our live Twitter conversation with the hashtag NVAFBeat. And you can also look at @CME Outfitters or at DLBotMD. We're all going to be following along on Twitter if you want to engage in that direction. We'll be monitoring that Twitter feed actively. One last item I want to note is we're using an enhanced platform today, some fancy stuff I should add, that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. It's really state-of-the-art CME platforms. Please look at the tabs on your screen and give us your feedback on the program and our new platform as well. As I mentioned, I'm Dr. Deepak Bhatt, Executive Director of Interventional Cardiovascular Programs at the Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School in Boston, Massachusetts. Let me introduce our faculty joining me today. It's really some great faculty. I'd like to welcome my colleague, Dr. Edith Netescu, who is the professor and head of the Department of Pharmacy Practice, and Michael Reese Endowed Professor of Cardiovascular Pharmacotherapy at the University of Illinois in Chicago. And she's at the College of Pharmacy there in Chicago, Illinois. I've known her for a while and really lucky to have her here. Welcome, Edith.
Thank you, Dr. Bhatt. It is a true pleasure to be here, and I'm looking forward to interacting with all of you tonight who are participating live in tonight's program.
Yeah, I think it's going to be fun. I'd also like to introduce my colleague, Kazuhiko Kido. And Dr. Kido is Clinical Assistant Professor of Clinical Pharmacy at West Virginia University School of Pharmacy in Morgantown, West Virginia. I love Morgantown. I've been there many times. Welcome, Kazu.
Yeah, thank you, Dr. Bart. And I'm also excited to be here to share some new upcoming information regarding the morbid obese patients using the anticoagulation for the populations. Thank you for inviting me today.
Yeah, great to have you and your insights and wisdom. So let me review our learning objectives. Our first learning objective is to assess existing guidelines and U.S. prescribing information for use of non-vitamin K oral anticoagulants, or NOACs, you'll hear us call them, and warfarin to prevent stroke in obese patients with non-valvular AF, or atrial fibrillation. Our second learning objective is to evaluate safety and efficacy data for NOACs and warfarin in obese patients with non-valvular AF. And our final learning objective is to counsel obese patients with non-valvular AF on risks and benefits of NOACs and warfarin to optimize adherence and health outcomes. So I want to start by getting all of you in the audience involved here in considering a case study, and then I'm going to ask a question about it, so please pay attention. So we have here a 63-year-old female presenting to the hospital for new onset atrial fibrillation. As you can see, she's clutching her chest. Her past medical history includes hypertension and diabetes. The weight is 130 kilograms, but more importantly, the body mass index is high, 45 kilograms per meter squared. Her vitals, blood pressure 130 or 85, heart rate 90, respirations 22, temperature of 36.5. She's currently on 81 a day of aspirin, lisinopril 10 milligrams a day, metformin 500 milligrams twice daily. She has no known allergies. And all the labs that we've got, at least on this initial screen, are within the normal range. So let's go ahead now and see what you think. This is the audience response part of things. You get to vote. So the question is, which anticoagulant would you personally recommend for this patient? And the options are shown on your screen. A for warfarin, B for apixaban, C for rivaroxaban, D for dabigatran, E for doxaban, or F for I don't know. So please go ahead and vote. And perhaps while the audience is thinking and voting and cogitating and so forth, maybe I'll just turn to my esteemed co-faculty and say, get your minds in gear, think of what you think the right answer is, because when we see the answers from the audience, I'm going to ask both of you to opine. All right, so let me turn to the faculty. Maybe Edith, we'll start with you. What would you say is the right answer here?
So in this case, several factors would have to be considered. Of course, Dr. Bhatt, as you highlighted, the patient's weight. The patient has a BMI of 45, concurrent therapy, important to note, aspirin, of course, the indication for therapy here, and the risk for stroke. And so in this case, given the patient characteristics, the risk of stroke, I would go with apixaban, and later in the presentation, we'll see why that is. And so what is the data behind one of the NOACs versus more traditional options such as warfarin?
And Kazu, do you have any differing opinion?
Yeah, I agree with the Dr. Newtescu. So probably the NOAC will be appropriate based on the upcoming result we're gonna talk about today. But if you follow the ISTH statement specifically that we're gonna talk about, probably warfarin is also appropriate. So we're gonna talk about the case-by-case approach to see which agent will be better for these patients.
Terrific. Well, so some room for discussion and learning for all of us. So let me start now by addressing the topic of obesity and atrial fibrillation. That's an important topic for sure. So the numbers are shown on this slide. 35 to 40% of adults in the US are living with obesity. It's an independent risk factor for atrial fibrillation. That's not so commonly appreciated, I think, by folks out there, but the data really do support that. And it frequently coexists with other AF risk factors, including hypertension, type 2 diabetes, chronic kidney disease. These things often move in packs. Obesity accounts for about 1 in 5 of all AF cases. Risk is increased by about 3% to 7% per incremental BMI unit. And obesity results in atrial remodeling, increased atrial size, interstitial fibrosis, pericardial fat infiltration into atrial myocardium, and heterogeneous and slowed conduction. Well, after seeing that, I don't feel like eating dinner anymore. So the epidemiology of atrial fibrillation in the US is shown here, but the bottom line is there is a rising prevalence. As of 2010, going back a decade, prevalence estimates for AF in the US range from about 2.7 million to 6.1 million. And the AF prevalence is predicted to increase by up to twofold by 2030 to about 12.1 million. And I think that's actually quite an underestimate. There's probably going to be even more between the aging of the population and growth in the population and other sorts of trends. There's going to be a lot of AF. I'm just going to ask anyone that isn't speaking, by the way, just to mute. There's a little bit of background noise. So as far as the clinical presentations of atrial fibrillation, there are lots of them, and they're shown here. Lightheadedness, palpitations, syncope, dyspnea, fatigue, chest pain, thromboembolism, death. That's a particularly bad clinical presentation. But as it turns out, people with atrial fibrillation actually do have a higher risk of sudden cardiac death as well, among all the other problems that are associated with atrial fibrillation. It's important to realize, though, that atrial fibrillation can be asymptomatic, and the impact of asymptomatic atrial fibrillation is the potential for underlying electrical and structural change, damage to the atrial myocardium. And while AF symptoms alone may not always be severe, untreated disease can also result in significant morbidity and mortality, like stroke. So shown here is the cumulative incidence of cardiovascular death, MI, or stroke after atrial fibrillation. These are data from the International REACH Registry, but there are other registries and data sets that basically show the same thing. And you can see here the much higher rate of ischemic events, not just stroke, but also MI and also CV death in those with atrial fibrillation in their history versus those without. Now, some of this is directly causal, as in stroke, and that's non-fatal or fatal stroke. Some of it is sort of epiphenomenon. That is, the MI risk is largely due to the shared risk factors for both atrial fibrillation, myocardial infarction, things like I mentioned already, things like obesity and diabetes. You know, it's a controversial question out there. How much AF do you need to increase the risk of stroke? This slide, I think, nicely summarizes the data going back a bit in time in terms of how long you might have AFib, or your patients might have AFib, and what the hazard ratio is for stroke. So even 5 minutes of atrial fibrillation is associated with, about a 2 to 6 or more fold excess risk of stroke. So even a short period is associated with a higher risk of stroke. And certainly if it's been present for more than a day or so, the risk of stroke, as everyone I think knows, goes up quite substantially. Exactly where that transition point occurs still is a matter of a bit of debate. And more importantly, when it should be a threshold for therapy, that is for anticoagulation, is also something that is a bit up in the air and a source of lots of ongoing studies. It's important to risk stratify for stroke and atrial fibrillation. We used to do this with the CHADS score, but now that has been eclipsed by the CHADS VASC score. And you can see there with the older CHADS or the more recent CHADS VASC, the higher the risk score, the greater the annual risk of ischemic stroke. And let's just focus on CHADS VASC in orange there. You can see the more risk factors, the risk of stroke really does go up. But it does actually go up even with a CHADS VASC of 1. So really anything at 1 or higher, I think, is worth at least considering treatment for. We'll get into things like guidelines. There's some difference between the US and the European guidelines. But before drowning in guidelines, just take a look at these numbers here. So yeah, obviously CHADS VASC of 2, 3, 4 is worse than 1, but 1 is no free lunch either. There's also the potential for risk stratifying based on bleeding risk scores, and HAS-BLED is one of those. You can see there the different points that go into the categorization or compilation of HAS-BLED, and I think it's useful to at least be aware of these risk factors for bleeding and think about them. Things like abnormal liver or renal function. Everybody, I believe, intuitively knows those things raise the risk of bleeding. Obviously, if someone's had a stroke, that can raise the risk of bleeding, in particular intracranial bleeding, but even other bleeding because of the other associated risk factors that go along with having had a stroke. Prior bleeding is a good predictor of future bleeding. For folks on warfarin, a label INR can spell trouble. Older patients are, of course, at high risk of bleeding. And if you're throwing in drugs or alcohol, that certainly can raise the risk of bleeding. There are other scores out there for bleeding, the hemorrhages, atria, or orbit scores as well. There are other ways of doing it. I must say, I'm not convinced that any of the bleeding risk scores really are in common use, but it is at a minimum worthwhile thinking about those things that lead to a high bleeding risk score. And here are the 2019 ACC AHA HRS guidelines for atrial fibrillation. Everything listed here is a level 1 recommendation, meaning you ought to do it. The levels of evidence might vary a little bit, but the class 1 recommendation means you really ought to be doing these things. So let me just quickly go through these. For patients with AF and a CHADS VASC score of greater than or equal to 2 in men or greater than or equal to 3 in women, oral anticoagulants are recommended. Options include warfarin, dabigatran, rivaroxaban, apixaban, or edoxaban. And as I mentioned, I might have a slightly different views with respect to CHADS VASC that are lower in both men and women, but we can discuss that later. But I think even at 1, men and women, if they're at low bleeding risk, certainly may benefit from anticoagulation, in particular with a NOAC, if they're a good candidate for that. But speaking of NOACs, dabigatran, rivaroxaban, apixaban, edoxaban are recommended over warfarin in NOAC-eligible patients with AF. So modern medicine actually prefers NOACs to warfarin in AF, except if they've got moderate to severe mitral stenosis, and of course, if they got a mechanical heart valve, warfarin and an INR range that is appropriate for that valve still remains the standard of care. Among patients on warfarin, the INR should be determined at least weekly during initiation and at least monthly when it is in a stable range. In patients with AF, except the two situations I mentioned before with respect to mitral stenosis and mechanical heart valves, the CHADS VAS score is recommended for assessment of stroke risk. For patients with AF who have mechanical heart valves, their warfarin is recommended. Selection of anticoagulant therapy should be based on the risk of thromboembolism, irrespective of whether the AF pattern is paroxysmal, persistent, or permanent. That's really old-fashioned thinking where we used to say, oh, it's just a little bit of paroxysmal AF. The risk of stroke shouldn't be too bad. It's not permanent AF. That thinking is clearly wrong. Renal function and hepatic function should be evaluated before initiation of a NOAC and should be reevaluated at least annually. Of course, in some patients, especially when using NOACs, you want to be aware if they've got fluctuating renal function, especially if they're on the lower range of the GFR to begin with, because there might need to be dosage or other adjustments. All right, well, now, Edith, can you take us through an overview of the current NOACs we have available for stroke prevention in patients with non-valvular AF?
Absolutely. And so on this slide, what you see is an overview of the 4 NOACs currently approved in the US for stroke prevention in AF patients. The first column highlights some of the key characteristics of the 4 agents listed here: dabigatran, rivaroxaban, apixaban, ledaxaban. And so, of course, 3 of these are factor Xa inhibitors, but dabigatran being a direct thrombin inhibitor. 2 of the agents as highlighted here are dosed once a day. 2 agents, dabigatran and apixaban, are dosed twice a day. The peak to onset, or time to onset, I should say, and time to reach peak effect is rather quick, and it ranges anywhere from 1 to 3 hours with apixaban, up to about 2 to 4 hours with rivaroxaban. Half-lives are also listed here. You could see the shorter half-life, 5 to 9 hours with rivaroxaban, and then a bit longer, up to 14, 17 hours with dabigatran. In terms of renal clearance, the NOAC that has highest percent of renal dependency is dabigatran, about 80%, about 1/3, around 30% or so with apixaban and rivaroxaban, and ledaxaban, about 50%. Drug-drug interactions, all of them interact with PGP inducers or inhibitors, and then of course rivaroxaban, apixaban can also have interactions with CYP 3A4 medications that are metabolized through this enzyme system. In terms of effect of food, rivaroxaban has to be taken with the evening meal in terms of better bioavailability that results from taking with food, but food has no effect on the other 3. And of course, when we look at the status of an available reversal agent, rivaroxaban, apixaban have andexanet alpha and either suzumab for dabigatran. Now, next, I'd like to review with you renal dosing adjustments in AF patients with the 4 agents. Again, you see the creatinine clearance listed in the first column and dosing adjustment recommendations with the 4 agents. Apixaban, dose adjustment is recommended based on creatinine clearance specifically. However, a dose decrease is recommended for patients that have 2 or more of the following characteristics, such as age equal or greater than 80 years, body weight less than or equal to 60 kilograms, and a serum creatinine of 1.5 or higher. Otherwise, the dosing, of course, you see here is listed as 5 milligrams twice a day. Now, with the other 3 agents, if the clearance is less than 15, or the patient is on dialysis, these agents are not recommended to be used. And then for some of the agents, for the clearance range of 30 to 50, such as edoxaban, for instance, you see a dose decrease recommendation, and 15 to 30 for the dabigatran, and 30 to 50 for rivaroxaban. So this, in a nutshell, very quickly, is a peek and a rapid overview of what we would do in terms of renal dosing in AF patients. Next, I would like to also briefly review some considerations in terms of hepatic disease. And so in those patients with Child-Pugh class A, as you could see here, no dose adjustment required. Those with class C, the 10As are not recommended. Interestingly, for the dabigatran, no dose adjustment required, but when we look at class B, what we're seeing is a fairly large intersubject variability, and no, interestingly, no evidence of a consistent change of exposure in pharmacodynamics. Rivaroxaban, edoxaban in class B are not recommended, and with apixaban, the label recommends use with caution only, but specific recommendations on how we would use this with caution are not provided. I think my next slide focuses on drug interactions. Yes, so I wanted to also briefly review with you some key highlights in terms of drug interactions, and so all of the agents would have to be avoided with PGP inducers such as rifampin. And then looking at the specific agents, some things I would like to highlight, for instance, for dabigatran with PGP inhibitors, if the clearance is 30 to 50, we would reduce the dose, and a clearance of 30, we would not use the agent. In terms of combined PGP and strong 3/4 inhibitors, agents such as ketoconazole, itraconazole, ritonavir, we would avoid the use of rivaroxaban. And for apixaban, for instance, we would reduce the dose by 50% if the patients receive a dose of 5 or 10 milligram, but if the patient already is receiving a reduced dose of 2.5 milligram, then in that case, avoiding apixaban is recommended. One other thing I would like to highlight here is for combined PGP and moderate 3/4 inhibitors, such as erythromycin, diltiazem also fits this category. For rivaroxaban, the recommendation is not to use in patients who have a clearance of 15 to 80 mLs per minute, unless potential benefit justifies potential risk. So this is because of the increased concern of drug accumulation, rivaroxaban accumulation, and potentially heightened risk of bleeding in patients that would take a combined PGP and moderate 3/4 inhibitor.
Well, thanks, Edith. That was extremely useful. I want to now myself shift to show some of the data on efficacy and safety of the current NOACs and how they compare to warfarin. So let's shift gears a little bit to do that. So here's a meta-analysis of 4 phase 3 trials looking at stroke and systemic embolism type events. And what you see here is that NOACs are better than warfarin. I would say that that is true in the individual trials, and certainly now pooling all the data, as was done by my colleague here at the Brigham, Christian Ruff, that there is a statistically significant reduction in these events in favor of NOACs. So really, this is what I think serves as our basis for preferring NOACs over warfarin. That was the efficacy side of the equation. What about the bleeding side of the equation? Well, in general, in these trials, the NOACs looked either similar to or better than warfarin with respect to major bleeding when we lump all types of major bleeding together, such that in the meta-analysis, once more, the NOACs win over warfarin. One can quibble about specific p-values and such, but I'd say as a class, this is true, though it was a bit more robust in the individual trials when one looked at Aristotle and Engage-AF. I should point out for intracranial hemorrhage, it was a clear-cut win, about a 10% reduction that was seen in that meta-analysis and was consistent across trials as well. So, here's major bleeding, but the intracranial hemorrhage part of things, there's no real discussion or ambiguity. Strong win for NOACs over warfarin. An issue, however, because of fears of bleeding with warfarin that have transferred over now to fears of bleeding with NOACs, is underdosing. The intent comes from a good place. In general, doctors are wanting to prevent bleeding and other complications, and therefore, using logic, figure, okay, this patient's older, they're at higher bleeding risk, and therefore I'm going to use less NOACs so that they'll have less bleeding. Again, well-intentioned, makes sense, but unfortunately the wrong thing to do in most cases. And in a sample of about 13,000 patients in the US with no renal indication for dose reduction, approximately 13% still received a dose reduction. And it was most common in the sort of patient I mentioned, somebody over 80, but also in those folks with a CHA2DS2-VASc score greater than or equal to 4. So folks that would benefit the most, in fact, from being on a NOAC or on anticoagulation in general. And of course, patients that were at high bleeding risk or also often at high stroke risk were ones where there was less utilization. And, there have been similar studies. There were 8,000 patients in a study from Israel, for example, basically showing, again, a large percentage, in that case, 39% receiving off-label dose-reduced treatment. So if the label says to reduce the dose, such as for issues of renal function or other reasons, well, follow the label. The labels are based on good data. But if the label doesn't say to reduce it, when you reduce it, then the patient doesn't get the benefit, but is still exposed to some sort of bleeding risk. And that's what the data at the bottom says in terms of potentially losing some of the benefit on thromboembolic complications, but still having bleeding hazard from that approach. Here we see the efficacy and safety of NOACs versus warfarin in patients with moderate CKD. And the point here is, even in those patients with some degree of renal dysfunction, a moderate degree of renal dysfunction, it does appear from what data we have, realizing that there's not a ton of data in general in patients with CKD, that NOACs still emerge as the winner. Certainly not worse than warfarin in any case, but in many cases, with respect to efficacy, better, and bleeding, at least not worse, and depending on the trial, perhaps even better. So even in patients with moderate CKD, respecting the label, dose adjusting if appropriate, it does seem like NOACs are the way to go over and above warfarin. All right, well, I've pretty much gone through some of the data with respect to the issues of renal dysfunction and other sorts of things that come up frequently. Now I want to shift gears a little bit, or actually have Kazu shift gears a little bit and speak what our main theme about tonight was really focused on, and that is patients with obesity. We've discussed some of the other challenges and things that really everyone using NOACs needs to know about in the non-valvular AF population, thinking about hepatic dysfunction, renal dysfunction, underdosing, etc. But what about patients that are obese? There are a growing number of patients. What do we do with these patients? And to gain insight on that, let me hand over the floor to Kazu.
Thank you, Dr. Bart, and I'm glad to share some upcoming results. But before we move on to the actual study data, let me start with the obesity paradox. So what is the obesity paradox? So theoretically, we expected that obesity was associated with higher risk of cardiovascular death, cardiovascular disease, or all-cause mortality. However, the actual study data shows that obesity status was associated with the reduction of the stroke or systemic embolism, all-cause mortality, or cardiovascular death. So there is the conflicting things between the theory and the actual data. So this is called the obesity paradox. So what kind of the data supports the obesity paradox theory? So here is the meta-analysis that including the patients, and including the studies of the Aristotle trials, which is the apixaban versus the warfarin, and the Rocket AF trial, including the rivaroxaban versus the warfarin, and the Relay trial, which is the dabigatran versus the warfarin. And then these meta-analysis compiled all of the data into the meta-analysis format. And then for the stroke or systemic embolism in the upper side, and then lower side is for the major bleeding. And then this meta-analysis showed that the obese patient was associated with significantly lower rate of stroke or systemic embolism compared to the normal weight patients. They're based on the odds ratio 0.62 and 95% confidence interval did not cross 1. And then moving on to the major bleeding, and compared to the normal weight patients, the obese patient was associated with significantly lower rate of major bleeding compared to the normal weight patients. So this meta-analysis supports the theory of the obesity paradox. So having said that, ISTH, International Society of Thrombosis and Hemostasis statement came out in 2016. And then the statement recommended the use of warfarin over NOACs for morbid obese patients with BMI greater than 40 or weight greater than 120 based on the two big reasons. One reason was the limited clinical evidence available at the time. And the other rationale for this statement was the PK pharmacokinetic variations in the NOACs based on the weight that some study shows. So therefore, the statement also recommended that if the NOACs are selected for the morbid obese patients, that checking the trough and the peak levels are suggested. And then if the levels within the expected range, then NOACs continuation will be recommended, versus that if the levels goes below the expected range, the warfarin was recommended. So is this true, or do we need to follow the ISTH statement for all of the morbidly obese patients, or do we need to take a case-by-case approach to individualize the anticoagulation therapy for morbidly obese patients? So since March 2016 to the December 2020, time flies by, but it's been 4 years since the ISTH statement came by. And then since then, the multiple study came out to evaluate the efficacy and the safety of the NOACs in the morbid obese patients with atrial fibrillations or venous thromboembolism. Therefore, we need to evaluate those to assess. Do we need to follow the ISTH statement for all patients, or we could use NOAC based on these trial came out over the last 4 years? So before moving on to the clinical studies, let me introduce the pharmacokinetic studies in the morbid obese patients. So here are two single-dose pharmacokinetic studies. On the left side, rivaroxaban single-dose study versus on the right side, apixaban single-dose pharmacokinetic studies. And then rivaroxaban single-dose pharmacokinetic study included the 3 cohort based on the weights, the less than or equal to 50 kilo, 70 to 80 kilo, which was the reference group, versus the morbidly obese patient greater than 120 kilo. And then studies showed that the morbid obese patients group and the reference groups had a similar Cmax value and also area under the curve values. And then study also showed that the rivaroxaban, the calibrated anti-10 activity was similar in all 3 weight groups. So therefore, the study concluded that there was no significant differences in the PK profile among the weights. Then moving on to the apixaban single dose. So this study included the 54 healthy subjects looking at the 3 different cohorts based on the weight, less than 50 kilo, 65 to 85 kilo, which was the reference range, and then the morbidly obese patients. And then compared with the reference group, actually the morbid obese patient had a 31% lower Cmax and a 23% lower area under the curve. So that means that there is some PK variation among the NOACs, especially the apixaban had some the PK variations. So that to put all these information together, that there may be the PK variations. So the PK profiles in the morbid obesity patient will be the NOAC specific. So there is a concern. So therefore, we may need to suggest monitoring the NOAC level. So what are the NOAC levels? So let me explain the NOAC intensity and the levels. So the intensity means the qualitative assessment versus the NOAC level means the quantitative assessment. For the bigger trends, we could use the APTT or thrombin time for intensity, which means the finding the presence of the medication in the system, but it does not measure the levels. Versus for levels, for the bigger trends, we could use the diluted thrombin time and the eccrine chromogenic assay or eccrine clotting time. And if the levels is in the lower range, liquid chromatography or mass spectrometry could be used to measure the lower level accurately. And then for the anti-10A inhibitor, apixaban, rivaroxaban, or edoxaban, the prothrombin time for the apixaban may not be recommended due to the lower sensitivity versus the rivaroxaban and edoxaban, the prothrombin time may be used to detect the presence of the medications in the system. Versus for the level for quantitative assessment, chromogenic anti-10A assays are used to measure the levels. And if the levels is in the lower range, the liquid chromatography or mass spectrometry may be used to measure the levels accurately. However, due to the availability, in general, the chromogenic anti-10A assays are most common way to measure the levels. So what are the NOAC level ranges? So here is the data from Sam Ellison and the colleagues in the CHEST journal, the systematic review showing that the expected steady state ranges. So here I want to highlight that these are the expected steady state ranges, not the therapeutic range. So we expect if the patient received the standard dosing of the NOACs, that we expect the patients to have these ranges. So considering those information, so what are the actual NOAC pharmacokinetic studies available in the morbid obese patients in the real world setting? So over the last 12 months, there were 2 studies came out to illustrate the effect of the NOACs in the morbid obese patient from the pharmacokinetic perspective. So the first study was conducted by Martin and the colleagues, the prospective observational study, including using the apixaban or rivaroxaban standard dose for the AFib or venous thromboembolism patients. The 116 samples were included, and then cohort mean body weight was 139 kilo, and then mean the body mass index was 45, and then 84% was morbidly obese patients. So it means majority were morbidly obese. And then the study showed that there was no linear relationship between the trough or peak anti-10 levels and the body weight or body mass index. So that study concluded that the body weight or body mass index did not affect the PK profiles of the apixabans or rivaroxabans. And then moving on to the another studies conducted by Speed and colleagues, the pharmacokinetic analysis, population pharmacokinetic analysis, looking at the use of the rivaroxabans in the morbid obese patients and the normal weight patients. And 913 patients were included from the 39 to the 172 kilogram of the weight, and opportunistic samplings was used, and a non-MEM software was used for the population pharmacokinetics. And then the data shows that the 2 pharmacokinetic parameters, the clearance and the volume of distributions, were influenced just by the lean body weight, and then total body weight and then BMI had minimal influence on the rivaroxaban PK parameters. So that means that the lean body weight is difference between total body weight and the fatty mass. So the larger fatty mass did not affect the PK profile. So that also supports the use of the rivaroxabans in the morbid obese patients based on these pharmacokinetic studies. So to put all these studies, pharmacokinetic studies together, from the pharmacokinetic perspective, the use of the NOACs may be supported over in the morbid obese patients.
Well, thank you very much, Kazu. Just to sum up what we've discussed so far, let me just make a few points here. Reducing stroke risk in patients with atrial fibrillation is essential, regardless of whether a patient's symptomatic or asymptomatic. NOACs are generally recommended as first-line therapy for stroke prevention in non-valvular AF. And compared with say 10 years ago, this is a big change. The obesity paradox theory may support the use of NOACs in morbidly obese patients, but we do need more data. Along those lines, measuring NOAC levels is suggested in patients with a BMI greater than 40 or weight greater than 120 kilograms, and choices are diluted thrombin time for the level of dabigatran effect and the chromogenic anti-10A levels for apixaban, edoxaban, or rivaroxaban. So, that's learning objective 1 that we've gone through. Hopefully that was useful to the audience. We've got a bunch of folks in the audience, by the way. It's over 400 people. And there are a lot of questions coming in that are great questions, so keep them coming in. So Edith and Kaz, I'm going to just turn to you before we move on to objective 2. And we've got a lot more material to cover, but there are just a lot of great questions.
Sure.
At least get through some of them. So if you could just keep your answers to 30 seconds or less, that will be useful. So this is a question, anyone that wants it can take it, although I think it pertains to the part we were talking, Edith, but the question is as follows. I thought rivaroxaban now has an indication for non-valvular AF and end-stage renal disease patients on dialysis.
The new test queue, you are muted.
Sorry. Okay. So not an indication per se. There's some additional language in the package insert in patients with renal impairment, but not end-stage renal disease. In those with end-stage renal disease and dialysis, the usage is still not recommended, and there's not an indication. I don't know, Kazu, if you want to add anything to that.
Yes, I agree. I think that's totally agree with you. That I think the official statement, that even though there may be some information, that data was just purely based on the single dose informations, in the dialysis patients. So it's early to tell that, the rivaroxaban could be used in the dialysis patients. But for the apixaban, that I could agree with that because, guideline now added the apixaban to the list of the anticoagulation for dialysis patients.
Yes, that's correct. It's in the apixaban label, even in dialysis patients. So there the dose is 5 milligrams BID in general, correct? Yeah, that is correct. I'll answer it myself. A lot of times people assume there would need to be a dosage reduction, but that's not in fact correct. All right, here's a question from Dr. Ryan in Utah. Hello, Dr. Ryan, good to hear from you. This question is as follows. In the SPEED study of rivaroxaban in obesity in AF, there is still a decrease in AUC and Cmax in high BMI. How do we take that into account when trying to decide about the risk of VTE at lower concentrations? Again, either of you that wants to take that, please go for it.
Sure, I will take that because of the relevant material from my side. So I agree that VT population versus the AFib, that's probably another discussion that we could spend for a whole 1 hour. But just to keep it simple, just for the VT, I agree that we have limited data than the AFib. So it's probably we have to be more cautious on using the NOACs in this population for VT patients versus the non-valvular AFib. So that's one thing. And then now a couple of the retrospective data came out over the last year, so we could keep an eye on those informations, and then hopefully that supports the use of the NOACs. And then even though there is some the PK variations, that outcomes data is more important than the pharmacokinetic data. So if the outcome data could support the use of the apixaban or rivaroxaban, regardless of the PK changes, we potentially could consider the use.
Terrific. Here's a question. I'll just take this one. Do you do CHADS-VASc on all patients greater than 60? That's a great question. I'm not sure if you mean, do I do it in AFib patients over 60? There, the answer is yes. Just because they're over 60, I wouldn't not do it. If the question is, do I do it in non-AFib patients over the age of 60? That's an interesting question. I mean, I tend to do CHADS-VASc where I am considering anticoagulation, and that's in the setting of atrial fibrillation. Having said that, there's studies, including one from the data that I alluded to here from the REACH registry, showing that the CHADS-VASc score actually does predict risk, even in patients without atrial fibrillation, predicts the risk of all sorts of ischemic events. So, perhaps as that gets integrated into electronic health records, we'll just calculate it in everybody. It's a reasonable thing to consider. Okay, well, there are a lot more questions here. Let me try to get through a few. Again, this is for anybody that wants to take it. For obese patients, should we use adjusted body weight in calculating creatinine clearance instead of ideal body weight?
So, I'll take a stab at this. I mean, this is, but I very much like to hear your opinions as well. This is controversial, a gray area answer because the data is not black and white. And so in practice, I can tell you that, at my institution, we tend to use adjusted body weight. But as I said, the data is not there for me to come out and say that's indeed, what we should be doing in practice. And so we know that that's a little bit different than what the large randomized trials have done, where actual body weight was used. So curious to see what you're doing at your institutions, Kazu and Dr. Bott.
Yes, I think that's a, go ahead, Dr. Burt.
No, please go ahead, Kazu.
So this is another gray area of the medicine. So I agree the package inserts definitely specify the actual body weight needs to be used for creatinine clearance. However, that study did not include the super morbid obese patients. So we do not, estimate based on the actual body weight for these patients. So I agree with using adjusted body weight in the real world setting.
Terrific. And maybe we'll take one more, then we just got to keep moving here. So most institutions have anti-10A monitoring specific to low molecular weight heparin or unfractionated heparin, but not anti-10A levels specific for NOACs. How reliable are these anti-10A labs when looking at NOAC anti-10A levels? It's a good question.
Yes, so I probably take the question just to see. So the question was the availability of the NOAC calibrated anti-10A. So I agree with that. So the most of institutions just have the heparin and the unfractionated heparin versus the low molecular heparin anti-10A. So now there is a couple of studies showing some correlations between the heparin or low molecular heparin anti-10A versus the NOAC anti-10A concentrations. So therefore, we could use as a qualitative assessment. However, it's too early to use for quantitative assessment. So if you want to use the actual measurement of the level, that even though it's a sent out lab, it takes 3 days, that I recommend using the outside lab. So, but a qualitative assessment, there is some data coming up over the last few years to use the alternative, the low molecular heparin or heparin anti-10A for that reason.
Great answer. And there's a ton more questions about obesity, but maybe now let's turn to our second learning objective to evaluate the safety and efficacy data for NOACs and for warfarin in obese patients with non-valvular AF. I think that'll answer a lot of the great questions that are coming in specific to that topic. And along those lines, Kazu, can you show us the actual data?
Yes, absolutely. Okay. So, as we discussed, since the ISTH statement, the multiple study came out. So let me start with the post hoc analysis of the Aristotle trial, which was the apixaban versus the warfarin. So there are two post hoc analyses on the left side, BMI-based subcategories versus the weight-based categories on the right side. And then just to keep in mind, about 1,000 patients were morbid obese patients based on the BMI, the Aristotle post hoc analysis, and looking at the apixaban versus the warfarin. And then the primary outcome was stroke or systemic embolism. And the primary safety outcome was the ISTH major bleeding. And then the study found that there was no significant interaction between the interventions and the BMI in the primary efficacy outcome. So that means that the BMI did not affect the benefits of using the apixabans in the morbid obese regardless of the BMI. And then for the safety wise, there was no significant difference in the major bleeding rate between the BMI greater than or equal to 40 and then the other BMIs. So it means that regardless of BMI, the safety data due to the apixaban versus the warfarin persisted in all subgroups. And then moving on to the post hoc study based on the weight. and about 982 patients classified as the morbid obese patients, same interventions and then outcomes, and there was no significant interaction between the three weight cohorts for the composite endpoint of the stroke or systemic embolism. So to put all these studies together, there seems like there was no significant difference in efficacy and then for the safety, regardless of the BMI or weight for that based on the Aristotle post hoc analysis. So how about other trials? So here is the meta-analysis conducted by Wang and colleagues and looking at the other clinical trials, including the Aristotle Relay, Rocket AF, Aristotle, and Engage AF TIMI trial. Relay trial for the bigatran, Rocket AF for the rivaroxaban, Aristotle for the apixaban, Engage AF TIMI for the doxaban. And then for the first BMI subgroup from 30 to 35, and then there was no significant difference between the NOAC and the warfarin in the efficacy, the stroke prevention outcome versus the use of the edoxaban was associated with significantly lower event rate of the stroke compared against the warfarin based on the 95% confidence interval. Looking at the next cohort, 35 to 39.99, the use of the apixaban was actually associated with a significantly lower event rate of the stroke compared against the warfarin. And then there was no significant difference between the edoxaban and the warfarin. And then specifically looking at the morbid obese patient subgroups, we talked about the Aristotle trial already. There was no significant difference in efficacy stroke prevention between the warfarin and the apixaban. And then keep in mind that actually the edoxaban study also had a morbid obese patients included, and there was no significant difference between the edoxaban and the warfarin. And then the overall result in the meta-analysis showed that the use of the NOAC was associated with significantly lower event rate of stroke compared against the warfarin. So what about the results of safety outcomes based on the BMI categories? The same BMI subgroups and the same clinical studies included. And then looking at the hazard ratio and the 95% confidence interval, there was no significant difference between the NOAC and the warfarin, regardless of the BMI subgroups. And then looking at the overall result at the end, the use of the NOAC was associated with significantly lower event rate of the major bleeding compared against the warfarin, and based on the 95% confidence interval did not cross one. So now we talked about the post hoc analysis of the clinical trials for the NOACs versus the warfarin. So what about the results in the real world setting? So since the ISTH statement, the three major study came out. On the left side, single center retrospective cohort study, that was very small studies looking at the morbid obese patient with atrial fibrillation based on the BMI and the weight. And the NOACs, the apixaban, the bigatran, or rivaroxaban were included versus the warfarin. And the primary efficacy outcome was stroke or TIA. Safety outcome was major bleeding. And then looking at the results, for efficacy, there was no significant differences between the NOACs and the warfarin. And then for the safety outcome, the ISTH major bleeding, there was also no significant difference between them. And then moving on to the Peterson and then colleagues, this was done based on the big data using the national insurance claim and including the morbid obese patient with atrial fibrillation based on the ICD codes, including the rivaroxaban versus the warfarin. The primary efficacy outcome of the ischemic stroke was systemic embolism, and the secondary outcome was major bleeding. And then looking at the results, similar to the first study, there was no significant difference between the rivaroxaban and the warfarin for the stroke prevention, and also for major bleeding, there was also no significant difference between them. And then looking at the third real-world studies conducted by Kushner and colleagues, including the apixaban or rivaroxaban versus the warfarin, efficacy outcome was stroke, and the safety outcome was major bleeding. For efficacy outcome stroke in the AFib cohort specifically, there was no significant difference between NOAC and the warfarin. And then looking at the safety outcomes, that there was also no significant difference, even though the the rate of the ISTH major bleeding was numerically lower in the NOACs group compared against the warfarin group. So to consider those information, so what is the result in the meta-analysis? So here is the meta-analysis conducted by my colleagues and myself for the stroke or systemic embolism event rates. So overall result, compared to the warfarin groups, the NOAC use, and then there was no significant difference between these two groups based on the odds ratio 0.85 and 95% confidence interval did cross 1. And then moving on to the major bleeding event rates. So similar trials included here, and then overall result at the end here. And looking at the odds ratio, the 95% confidence interval, actually the use of the NOACs was associated with significantly lower event rate of major bleeding compared against the warfarin, based on the 95% confidence interval did not cross 1. So now that based on the real world studies, the NOAC use was supported from the retrospective studies or post hocs of the clinical trials. So what is the larger the real world data in the the obese patients, so which is the Aristophanes obesity subgroup analysis? For efficacy, that the top Apixaban versus the warfarin, in the middle, the bigetron versus warfarin, and the rivaroxaban versus warfarin at the end. And then looking at the reference group versus the warfarin, and the hazard ratio 0.63, and then the 95% did not cross 1. So it means the Apixaban use was associated with significantly lower rate of the stroke or systemic embolism compared against the warfarin. And then looking at the dabigatran versus warfarin, there was no significant difference between the dabigatran and the warfarin. And then moving on to the last part, the rivaroxaban use was actually associated with significantly lower rate of stroke or systemic embolism compared to the warfarin, which is different from the ROCKET AF trial. So how about the results of the safety outcomes? Same format, Apixaban, warfarin at the top, dabigatran versus the warfarin in the middle, rivaroxaban versus warfarin at the end. The Apixaban use was associated with significantly lower rate of the major bleeding compared against the warfarin. And then the GI bleeding, intracranial hemorrhage showed the similar results. And then for the dabigatran versus the warfarin, the use of the dabigatran was actually associated with significantly lower rate of the major bleeding compared to the warfarin, which is different from the RELIGHT trial showing the comparable major bleeding rates. And then the GI bleeding rate also, there was no significant difference between dabigatran versus warfarin, which is also different from the RELIGHT trial showing the use of dabigatran was actually higher. The risk of the GI bleeding was significantly higher in the dabigatran versus the warfarin in the RELIGHT trial. So this data was different from the RELIGHT trial. And the ISTH, there was no significant difference. And the rivaroxaban versus the warfarin, major bleeding, there was no significant differences. But for GI bleeding, similar to the ROCKET AF trial, the use of the GI bleeding risk was significantly higher in the rivaroxaban compared against the warfarin, and the intracranial hemorrhage risk was significantly lower in rivaroxaban compared against the warfarin.
Well, thank you, Kazu. That was really terrific, and congratulations to you and your colleagues on that important work that you've published. I think it's so informative to the field, and it really moves us forward. There's a data void in terms of obese patients and what to do, and I think you've shed a lot of light with that work, so congratulations on that. Well, let me say a little bit about the incidence of GI bleeding. It's an important topic in real life practice, so let me at least share some data here. And this is specifically referring to upper GI bleeding risk with oral anticoagulants with or without a proton pump inhibitor. The no PPI co-therapy is shown in red, and the PPI co-therapy is shown in blue. And as you can see here, across the board with the NOACs and with warfarin, there are lower rates of GI bleeding with the PPI versus without. And this is in keeping really with what common sense would support, and also in keeping with some randomized trials, such as the Cogent trial that I led some years ago, where with dual antiplatelet therapy in a randomized trial, PPI was associated with less clinical GI bleeding than no PPI. So as with DAPT, also it appears to be the case here that with anticoagulation, there's a lower associated rate of GI bleeding if a PPI is prescribed. So just to conclude with learning objective 2, and then we'll move on to learning objective 3 here and wrap up in a little bit. Analysis of phase 3 clinical trial data and retrospective cohort studies support the use of NOACs in morbidly obese patients with atrial fibrillation. I think it's a real conceptual advance having both subgroup data from phase 3 clinical trials and retrospective cohort studies that both seem to take us to the same place. Well, now we're going to move on to learning objective 3, which is a pretty short series of slides we're going to do, and then we'll get to all the questions and answers. But let me just take a couple of questions before, because they're related to what was just presented, in particular by you, Kazu, right now. So while it's fresh on our audience members' minds, and the number of audience members is actually going up. It's surprising that on a Sunday night it's actually increasing going on. But the question to you was, looking at the randomized data and the observational data that you've just reviewed, it's pretty clear that NOACs are better than warfarin is the question. But among the NOACs, a number of people have asked which one is the best based on the data that are available now in that morbidly obese patient.
So that's actually the really tough questions, because there is no head-to-head study information to justify, but just regarding the amount of the information available for the specific NOACs, obviously, as we can see, the rivaroxaban and the apixaban has more data than the edoxaban and the dabigatran. Edoxaban advantage of using edoxaban is actually some populations were morbid obese patients in engage AFTME trials. That will be advantage, but the dabigatran, I couldn't see any positive data to support. So, just to simply put, the rivaroxaban, apixaban potentially will be, supported by the evidence because of the amount of the information, but it's hard to show the superiority one over the others.
Yeah, no, really, in the absence of head-to-head trials, everything we say is rather speculative. Rivaroxaban, of course, has the advantage of once a day, apixaban's twice a day. On the other hand, if one looks at the apixaban trials, even the data you showed, there, if anything, things like GI bleeding don't seem to be increased versus warfarin. With rivaroxaban, we have seen signals of increased GI bleeding.
That's actually really great points.
Yeah, and that can include lower GI bleeding, even though I was talking about ways to reduce upper GI bleeding with proton pump inhibition. So even if one just looks at the overall randomized clinical trials, perhaps that twice-a-day dosing, while in some patients could be an issue with lower adherence, in those who are adherent to it, might be an advantage in perhaps preventing the higher peaks that might be associated with provoking some bleeding episodes. But at any rate, we can debate that in our panel discussion. Now let's move on to our third and final learning objective, and that's how to counsel obese patients with non-valvular atrial fibrillation on the risks and benefits of NOACs and of warfarin as well, to optimize adherence and health outcomes. To start off this discussion, Kazu, can you walk us through a situation that a pharmacist might encounter in real life?
Yes, absolutely. So here is a case, the 74-year-old male with a past medical history of the atrial fibrillations who came to the cardiology multidisciplinary clinic for the regular follow-up. And as an ambulatory care pharmacist, you're reviewing his medication regimen prior to the physician's appointment, and he is morbidly obese based on the BMI and weight. And he's currently on the dabigatran 150 milligram twice a day for the atrial fibrillations. And his lab was significant for the serum creatinine 1.5, and estimated creatinine clearance is about 30. And then he also told the pharmacist he started taking the St. John's wort for depression, which was recommended by the primary care doctor 2 months ago. And then he also told the pharmacist that he doesn't know why he needs to stay on the dabigatran, and he feels that the medication does not give him any values, and he often forgets to take it about at least 1 or 2 times weekly. So based on that question, the case, what should the pharmacist do in this scenario? And then first one is the recommending switching from dabigatran to apixaban based on the morbid obese status or his renal functions. And the second option is the recommend stopping St. John's wort to avoid drug interaction with NOACs. And the third option is counsel patients on the indication of anticoagulation to improve the adherence for AFib. And then risk of the abrupt NOACs discontinuation should be discussed with the patients. And then the fourth answer is all of above. And the fifth answer is the I don't know. So we have a result. So Dr. Barrett and then Dr. Nutescu, based on the response, what did you guys all think?
I don't think the response is surprising. 81% of the audience picks option for all of the above. Of course, this case has several facets. There are issues of adherence. There are issues of drug interactions, patients not particularly keen with the current anticoagulant, of course, education on the importance of adherence and consequences of non-adherence would have to be discussed.
Yeah, I think that's a great answer. I mean, I would have picked number one. That is, I would have recommended switching from dabigatran to something, and probably apixaban due to the morbid obesity and also the renal function. I think number two, recommend stopping St. John's wort. It's going to be tough. The patient may not like that answer and may not do it. So it may not matter what I think in that respect. And, counseling on anticoagulation and the risk of stopping anticoagulation, that's always a good thing to do. So I guess of the choices, I would have probably gone with one, but I can see that, it's like real life. It can be a little bit messy and things aren't always so clear. So maybe, Edith, you can take us through another case, another real life case with real life challenges.
Absolutely. So what we have here is a 65-year-old African-American woman who has uncontrolled hypertension, diabetes, chronic renal insufficiency, clearance of 35, and hyperlipidemia. She comes to the ED with dizziness and palpitations. EKG shows AF at a rate of 110. Exam otherwise normal, labs otherwise within normal limits. We've already noted her creatinine clearance. You could see her BMI is at 47. Her concurrent medications, important to note, as we'll see, there's some that hit the drug interaction list with some of the anticoagulants. Social history, positive for 2 to 3 drinks per day. She's a widower who lives quite afar, about 30 miles from the nearest clinic. She has limited dexterity as well as trouble with transportation because she does not drive. She has Medicare Part D coverage, but is concerned about a high copay on her medications, which she can't afford. On top of it, she's forgetful and expresses a preference for medications that she can take once a day, as all her other current medications can be taken once daily. So this is a complex case and really not that unusual to what we see in an inner city, large academic hospital, where 60% of our population is African-American, about 20% Hispanic, 20% everybody else. But let's look at check in with our audience again. And so the question I would like you to consider here is that this patient presents to you with a prescription for warfarin, 5 milligrams daily. And what is your recommendation in this scenario? If you could please vote now. And so the options are A, fill her warfarin as prescribed, discuss selection. B would be discuss selection of therapy with the patient and the prescribing provider. C, recommend switching the patient to apixaban, given her weight and renal function. D, unsure. Okay, so very interesting results. About 50% pick option 2 discussed with the prescribing provider. The next biggest category, 35%, recommend switching to a NOAC, in this case, apixaban. But I would like to turn this now to Dr. Bhatt and Dr. Keto, and so get your perspective on the answers here.
Well, again, I think it's a tough question. It's real life. I guess I would have probably picked number 3, that is recommending switching the patient to apixaban given her weight and renal function. I don't think that number 2 is a mistake to ever discuss the selection of therapy with the patient, the prescribing MD. I mean, to me, that's one of those answers that's always correct. I think number 4 is also correct. Nothing wrong with being unsure in life. I probably wouldn't just go fill the warfarin as prescribed, though. That one I probably wouldn't have done. So myself, I would have gone with number 3, switching her to apixaban, given the weight and renal function and the data we reviewed. But I'd be interested in what Kazu has to say.
Yes, I agree with Dr. Bart and Dr. Nutescu. So definitely the warfarin may be tough based on the access to the INRs, and then based on the non-compliance history. Even though patients could check the INR, could see how the compliant patient is, but definitely the once we counsel patients on the NOACs, patient could recognize the pros of using the NOACs, and patient have better understanding. And then that counseling part may help improve then recognize the benefit of using NOAC. So if patient could get some like a patient assistance program, that might also help. But for the reason, I agree with choosing 3.
Great, thank you.
Well, Edith, do you want to go on?
Yes. So as we've seen in our patient case, there are a number of clinical considerations to sort through when individualizing selection of anticoagulation therapy, such as indication, of course, stroke risk, so weighing stroke risk versus bleeding risk, as already highlighted by Dr. Bhatt earlier in the presentation, drug interactions, weight, renal function, age, side effects, adherence, access to drugs, of course, medication costs, co-pays, and last but not least, very important, patient preferences. So a systematic approach to considering each factor that influences therapy can assist with the selection of the most appropriate and individualized anticoagulant therapy for each patient. Lack of considering patient-specific factors and not individualizing therapy can lead to high rates of therapy switching and/or discontinuation, as seen here on this slide. This is a study actually conducted by our group here at UIC. In fact, the first author is one of my former PhD students. This now has been published several years ago, but still very relevant in terms of results to our discussion today. So in a cohort of over 34,000 patients, anticoagulation naive patients with AF were newly initiated on NOAC therapy. What we've seen here is that 1 in 5 patients switched to an alternate anticoagulant. And 1 of every 2 patients did so within the first 6 months of therapy. So you could see these on my left-hand side of the graph, so left graph. While early switching over the initial 6 months from NOAC to warfarin was more common, this is depicted on my right-hand side, switching from an initial NOAC prescription to warfarin occurs as frequently as switching to an alternate NOAC over the study period. In another large real-world study looking at over 40,000 patients, we've seen similar results in that treatment persistence decreases over time, and we're seeing discontinuation of therapy increasing over time from 3 months to 12 months of therapy. More significant with some agents such as warfarin and dabigatran, but an overall decrease over time is noted here with all the anticoagulant agents. Now, yet in another study, again from our group, the same graduate student is the lead author in a cohort of over 66,000 patients now with AF, of which about half were anticoag naive and half were experienced on anticoagulation therapy. So when they came into our study, they were already on anticoagulant therapy. we found that persistence with NOACs declined over time, and both were suboptimal and lower in anticoag naive compared to anticoag experienced patients. These findings indicate the importance of interventions for patient education and long-term anticoagulant management, especially in those patients as depicted here who are naive to NOAC therapy. Now, one other important factor to consider in selecting the most effective and safe therapy in those at highest risk of complication due to AF is the risk assessment and anticoagulant therapy selection in minority patients. As illustrated on this slide, minority patients with AF who are at risk of stroke were less likely to receive any oral anticoagulant, and NOAC specifically, when compared to whites. And this was even after accounting for confounders such as insurance status, income, and stroke risk factors. Now, I think we can all agree that pharmacists play an important role in the care of patients with atrial fibrillation. Pharmacist involvement in anticoag management has been demonstrated to show improved adherence rates, reduction in side effects associated with anticoagulant therapy, and decrease in rates of anticoag-related ED visits and hospitalizations. And as you could see here in this graph, what we're showing you here basically is the effect of pharmacy-provided anticoagulant education on 60-day hospital readmissions. And so both overall readmissions, but most importantly, readmissions related to anticoagulant events or anticoagulant-related events were significantly lower in those patients who have received education by the pharmacist. Now, specific pharmacist intervention, again, to further illustrate this point, in this study published in JAMA back in 2015, we learned that specific pharmacist interventions are associated with greater NOAC patient adherence. So looking at guiding patient selection, patient education, and monitoring, but monitoring over a longer duration of period, over 12 months, and providing more intensive care to non-adherent patients improved adherence. Now, what are some of the factors that influence patient adherence?
And not to interrupt for this really important part about adherence, but we've got about 10 minutes before wrapping up the whole program. So just to help you yourself.
Thank you, Dr. Bhatt. And the last few slides we can go through fairly quickly. These are slides that our pharmacist audience is very familiar with. And so, of course, we have to consider patient-centered factors, therapy-related factors, healthcare system factors, and last but not least, social and economic factors. Now, pharmacists play a major role, of course, in collaborative therapy decision-making, starting with estimating benefit risk, of course, stroke risk and major bleeding risk, selection of appropriate candidates, recommending appropriate therapy, communicating with the team and the patients, and then last but not least, educating the patient. So all of these things, that have come up in some of the patient cases we've discussed, but more so in the third patient case, right? The importance of highlighting all of these patient-related and system-related factors. Now, patient-centered education is also supported and in fact required by regulatory bodies such as the Joint Commission. And just in interest of time, if we could jump on to the next slide. This brings up the importance of shared decision-making. Of course, not only because of not sufficient patients who are at risk to receive therapy, but also of those who start therapy, a high percent stop treatment over the first 12 months. And we've shown you data regarding this. And so because of these data, AHA, ACC, HRS guidelines note that shared decision-making can improve adherence to anticoagulant therapy. Next slide shows you specific patient preferences. To denote that considering patient preferences, individualizing therapy is critical. Patients put weight on stroke risk, safety, major bleeding, other side effects, but also conveniences such as dosing frequency, antidote availability, again, other conveniences such as taking with or without food and dietary restrictions. And I think this brings me next to my last slide, then, of course, just showing you some examples of shared decision-making. Many are out there, but the one that I personally like is this one put out by Mayo Clinic. This shows you an example of a patient with a CHA2DS2-VASc score of 3. The left-hand side here, you see very nicely depicted the risk of stroke. People who will have a non-disabling stroke in orange color, the lavender color, those who will have a fatal or disabling stroke, and then the green dots show people who will have no stroke if they're not an anticoagulant. To the right of it, what you see is if a patient's placed on anticoagulant, what is the benefit? And so this is very, very nice in terms of graphics on how we can best relay this type of information to patients. And then this Mayo program is also nice because it also has an education module. This is to the far right of the slide, and you can see some of the topics here depicted that you can discuss with the patient. And this brings me back to my last slide to summarize then some of the points that we've seen in our patient in the last case. Several patient-specific factors need to be considered when selecting oral anticoagulation for patients. Thrombosis and bleeding risk, weight, renal function, age, concurrent drug therapy, of course, patient preferences, cost are critical. So of course, individualizing therapy. Clinical decision support tools can aid in treatment selection and patient education. And of course, last but not least, a systematic approach to screening and discussing drug selection is vital for selection of the best agent, but individualized treatment for each patient. And with that, I think, Dr. Bhatt, I'm going to give it back to you.
Edith, that was just excellent. Thank you so much for that presentation. And you know, it's interesting, you're talking about that important topic of adherence, and I'm telling you to cut it short. I mean, that's what happens in real life. We just don't focus on adherence as much as we ought to. It's such an important topic, but it often gets short shrift. I do want to make our audience aware of another tool that you can use in practice, which is a patient education whiteboard video that can be found on the CME Outfitters website in the Cardiology Hub. So please take time to review the video and share it with your patients. It's one of the many resources that you can find on the CME Outfitters website. So at this point, let's wrap up by reviewing SMART goals that you can carry into your practice. Select appropriate anticoagulation at the appropriate dose. Utilize a systematic approach to screening, individualized treatment selection. Don't underestimate the risk of undertreatment. Consider measuring NOAC levels in morbidly obese patients where appropriate, and that would be the diluted thrombin time for dabigatran and the chromogenic anti-10A levels for apixaban, edoxaban, and rivaroxaban. Apply clinical study findings of NOACs and warfarin in obese patients with AF to appropriate patients in your practice. Engage patients in SDM and reinforce the importance of adherence and persistence. So go ahead now and ask a question. Actually, a lot of folks have already asked a question, but please keep submitting them. We've got about 7 minutes left, and we're going to use all that time to get through as much as we can. You can use the Q&A widget on your screen, and you can email questions to @cmeoutfitters.com, or you can even tweet us. I've been following along. I actually just saw Dr. Natescu in action on the live Twitter feed. It was really fun seeing her on the one Zoom screen, on the other Twitter feed. But let's jump in right now, and let's get through some of the questions. And then at the end, I've got to do a few housekeeping things. We have to save a couple of minutes for that. So let me start off with you, Edith. You were talking about many important things there, adherence and so forth. You were also talking about disparities in care. This question states, from the questioner, an African-American woman was prescribed warfarin. How to use patient copay reduction assistance when it is specifically prohibited by Medicare Part D. That's why I would most likely have to go with warfarin if she had limited financial means.
So excellent point. And the case that we've discussed intentionally was complex. And I must confess, there was not a single correct answer, right? So the correct answer was think about the combination of the various options and probably more. And so you're absolutely right on Medicare Part D, but here the options would be certain agents, would have a preferred status versus others who would not under different insurers. And so copays might be lower for some agents versus others. Could there be co-insurance in this case? Again, all of this information has not been provided. Now, obviously, if there's no co-insurance and all the copays are, let's say, $100 or higher, or tremendously high, and this patient cannot afford, then clearly then the option would be warfarin, right? But the point of this case was to really think about all that we need to consider. Some of the barriers, of course, she cannot come in for monitoring. What do we do with a patient like this? Then if she can't afford something, let's say the copay is high, there's no alternate options like a patient assistance program or anything else that could be used. Self-testing, home monitoring, right? So there are other options if she must stay on warfarin. So a lot more, right? To discuss here, but excellent point. And so again, looking at tier of coverage, patient assistance programs. If all of that fails, then obviously we'll have to stick with something that the patient can afford and would be adherent with.
Terrific answer. All right, there's about 50 other questions. I'll try to lump them together, and if you could each keep your responses to no more than 15 to 30 seconds. What advice do you have for patients on a NOAC who are initiated on a new therapy that is a strong CYP3A4 inducer? For example, St. John's wort is a potent CYP3A4 inducer. We've discussed that a little bit already. And so are several agents used in oncology, such as enzalutamide, which could reduce levels of NOAC anticoagulant levels. Should NOACs be avoided with this drug interaction?
So I'd like to hear Kazu's point of view here too. My personal approach here would be, so if we think of switching a NOAC, then the alternative here would be warfarin. And for those of you that have managed warfarin in an oncology patient, you know what a nightmare that is, and it's not an easy task, right? To maintain satisfactory anticoagulant levels. My preference here would be to try to switch the St. John's wort and so remove the interacting drug versus perhaps introduce another layer of complexity in this patient's case.
Okay, that's a terrific answer. Let me move on to the next question. Maybe I'll take this one. This has to do with whether it's okay to use NOACs in bioprosthetic valves and atrial fibrillation. This is a terrific and timely question. I would refer you to the New England Journal of Medicine. The RIVER study was just published there. It looked at AFib with a bioprosthetic mitral valve. The specific NOAC study there was rivaroxaban. It looked terrific. In fact, in many metrics, whether the p-values hit or not, it actually looked better. So I would say bioprosthetic valve, otherwise a good candidate for NOAC, no contraindications. At the present time, I would do it over warfarin. All right, here are a bunch of questions about factor 10A levels and so forth. The questions have to do with whether you can use factor 10A levels, can you monitor them? In obese patients, we've already said, yes, you can. What if you can't monitor 10A levels? Is it still okay to use apixaban in obese patients?
So that's actually the great questions. Availability of the anti-10A level is always the issue. So just, to simply put, so, based on the result, I think this is just if, we need to have a discussion with the patients, but, based on what we have for the retrospective data or post hoc analysis of clinical trial. But if we, pursue the routes that, the level, definitely there is still ideal to check it. But if not, rivaroxaban seems like had a consistently better PK profile. So that might be the option to consider, based on that, but we have to disclose the information to patients, see that if that's okay or not. And then, since the ISTH statement, still says checking levels.
And what would you do is another related question. Would you adjust dosing of NOACs based on the level? And if so, how?
So we do not have the therapeutic range yet. Not that, we only have expected range. So for the reason that dose adjustment will be risky. And then based on Dr. Bart and talked about for the underdosing concern. So for the reason, probably no adjustment is probably still required for that based on the level until we have more data.
And Edith, this question is to you, 15 seconds. Is there a significant difference in efficacy of rivaroxaban if it is administered with evening versus morning meal?
I must say I'm not aware of such data. My understanding is that it's the content of the food, and so apparently fatty foods would lead to better bioavailability.
Yes, no, that's correct. I think the nighttime is sort of a historical sort of remnant from warfarin, which was typically given at nights. All right, well, I think that's about all time we have for Q&A. To receive CME CE credit for today's program, click on the Evaluations tab to complete the post-test and print your certificate. Also, please check out our Cardiology Hub that contains resources we've selected for you and for your patients. And for more activities that offer ACPE credit, please check out the Virtual Education Hub, where you'll find programs across a variety of therapeutic areas. Thank you again for participating, and thank you for providing the best care for your patients. And really thank you to both the faculty members, Dr. Nitesu and Dr. Kido, for outstanding presentations and discussions. Everyone have a great night.
Thank you.